Senator Housley, if you'll proceed.
Thank you very much, Mr. Chair and members. I do have a author's delete all amendment for the Senate File 112.
I'm sorry.
Oh, I have a delete all amendment.
So you have an amendment A1, is that correct?
Yep, I'd like to get the bill in the shape that I'd like to have it heard. I would like to move the A1 amendment.
All right. Okay. Well, I don't know that we have a quorum here yet, but all in favor? We do. Oh, I'm told we have a quorum, so all in favor? Aye. Opposed? Motion carried.
Also, I have an A2 amendment.
All right.
I'd like to move the A2 amendment.
All in favor? Opposed? Amendment is adopted. I believe you have some presenters.
Yes, thank you, Mr. Chair and members. I just want to talk a little bit about the bill. This is a bill to establish a Palliative Care Advisory Committee. First, I just want to tell you a little bit about palliative care, then I'll introduce my presenters, my testifiers. Palliative care, just the word is a little new to our culture. What palliative care is, it treats the symptoms of serious diseases like cancer, Alzheimer's, ALS, congestive heart failure. And it treats the symptoms such as pain, depression, sleeplessness, nausea, and it's a newer area of care that we are focusing on here in the state of Minnesota. And so it was brought to me by the American Cancer Society Cancer Action Network to comprise an advisory committee to study this and see which areas we can focus on more, how we can get more workers into this area, and why we aren't achieving as many workers as we can throughout the state. I'm going to introduce my presenters so they can go into more of the details of the bill and what palliative care is. I've got to go ahead, introduce yourself for the record, and go ahead.
I'm Julie Benson. I'm a family medicine physician from Staples, Minnesota, and the president of the Minnesota Network of Hospice and Palliative Care.
I'm Margaret Potter. I'm a breast cancer survivor.
I'm Ellie Beaver with the American Cancer Society Cancer Action Network. I'm the Government Relations Director.
Oh, yeah, you go first.
Well, thank you, Senator Housley, Mr. Chair, members of the committee. I think you covered a lot of what I wanted to say about what palliative care is, but I also wanted to say that the reason that the American Cancer Society Cancer Action Network has taken on this issue of palliative care is because we feel we've done a really good job of raising awareness of cancer and of raising funds for research. And palliative care has been a gap in care for a lot of our cancer patients and other people suffering from serious and chronic diseases. And we support a stronger palliative care system in order to help our patients have better quality of life, live longer, and ultimately end up costing less over the course of treatment. So I will turn it over to Margaret Potter, who is a cancer survivor, and here to speak to you about her experience with palliative care.
Thanks, Ellie. Good morning, Mr. Chair, and members of the committee. My name is Margaret Potter. I'm a Minneapolis resident and a breast cancer survivor, and I'm here to speak in support of Senate File 112, or 112. I was diagnosed with stage 2 breast cancer in February of 2015. I elected to have 21 weeks of chemotherapy, followed by a lumpectomy, and then 6.5 weeks of radiation therapy. I was treated here in the Twin Cities at a hospital here. My family is up in St. Cloud, and my family, my employers, my coworkers including my then new boyfriend. He's here with me today. And they gave me and continue to give me a great deal of support. As treatment goes and as recovery goes, I did extremely well. I tolerated chemotherapy. I tolerated radiation therapy relatively well. I was pretty exhausted by the time I got to the end of it all, but and that was hard. It was hard to keep my spirits up. The period between end of treatment and getting back to work full time, it took me nearly a year, and that was a really long haul. And I wanted to be back to normal, and it was very frustrating. Palliative care could have made a big difference for me, a really big difference. During and after treatment, I was not seen by a palliative care team or specialist, and I didn't know to ask for palliative care. I wrongly assumed that palliative care was for people who had no more hope for treatment. I did receive treatments and pursue activities that qualify under the umbrella of palliative care, and I wish I'd had regular appointments with a specialist that could help me manage that. There were a lot of pieces, and during cancer treatment and during all of that stress, it was very hard to stay organized and stay on top of that. And a lot of those pieces were missed because my palliative care wasn't coordinated by somebody who knew the system and had a good brain. Palliative care, by definition, takes a broad variety of approaches to care and weaves them together to fit each individual patient. Not many cancer patients or anyone in chronic pain can really, has the energy and know-how to do that for themselves. If I'd received full palliative care coordinated through a caseworker, I realized that my recovery after treatment, when I was trying to get back to normal, would not have been so disjointed and difficult. I tried to get myself back on track through exercise, and I didn't have a trainer, and so through the course of that, I created a muscular imbalance that required that I see an orthopedist and a physical therapist just to eliminate the pain and get me back on track. Chronic pain was also really exhausting, and it hindered my recovery. I think if I had my care coordinated and not had these additional problems, I might have been able to get myself off of disability several months earlier and return to work, and that was really important to me. My story is only one of all the stories across this state where patients realize that palliative care could have done so much more. Please help to improve access and understanding about it, and remember my story when you vote for this 1112, Senate File 1112, to help future patients. Thank you very much.
Thank you, members of the committee. As I said earlier, I'm a family practice physician. I practice in Staples, Minnesota, rural central Minnesota. I do a full breadth of practice, obstetrics, pediatrics, geriatrics, and I'm also the medical director for our hospice and palliative care program. I sit as president of the Minnesota Network of the Hospice and Palliative Care, and we are an organization that brings together providers, business partners, and individuals to advocate, to increase knowledge and increase access and services for people who experience serious serious life-threatening illnesses, and sometimes end-of-life illnesses as well. And I'm also here to speak in favor of Senate File 112. As you heard earlier, palliative care is specialized medical care that really deals with a team, an interdisciplinary team, to help add support to the patient and their primary team. It includes physicians, social workers, nurses, pharmacists, therapists, chaplain, to really look at from the whole psychosocial aspect of providing care. It's appropriate at any stage of a serious illness and at any age. We do pediatric palliative care as well. Palliative care has been shown to decrease readmissions, decrease lengths of stay in the ICU, deaths in the hospital, but most importantly also to increase patient and family satisfaction. And it perfectly meets the goals of the quadruple aim. As you know, better health, lower costs, better experience, and improved clinician satisfaction. I personally work at a critical access hospital, and in 2008, we began developing our palliative care program. We knew the data showed that it would decrease ED stays, it would decrease our readmissions, and in the long run, it would actually save our payers, our insurers, money. But a critical access hospital is not paid that way, and so it actually meant decreasing our revenue on our bottom line. My CFO was not terribly thrilled with that. But my team and my administrative team knew that this was really good patient care. And this is before the Accountable Care Act. This is before it was right to do triple aim and quadruple aim. This is before it was the thing to do. So, you know, I'm very blessed to have that, but just to understand that that actually comes with a cost for us as well. And unfortunately, my hospital is a rural hospital, is an outlier. The majority of small hospitals don't have access to palliative care like this. And even where there is access in metropolitan areas, only about 1 in 10 patients have access to palliative care. And there's a couple of different reasons for that. Part of it is a lot of clinicians don't know to offer it. We think it's for people at the end of life, like you heard earlier, for people when there is nothing further to do. And that is not at all true. This is really about living. There really aren't enough trained professionals right now to do this. In general, as far as training goes, when I'm in medical school and then on to residency, I will have upwards of 12 weeks doing obstetrics. That's going to affect 50% of my population. 100% of us are going to die. More than 90% of us will be over a period of time, sometimes with significant debility. In training, you might get 2 weeks focused on this. And I think that's a big discrepancy. There's a huge knowledge gap when it comes to that. Providers are usually unaware of when to offer palliative care. They sometimes don't have really good patient-doctor communication skills about some of these things. They think that the patient's going to ask for it, and the patients think the doctor's going to tell you about it. And we don't understand that. Sometimes we have a lot more things we can do with pain and symptom management. We feel like pain we can sometimes manage better than perhaps fatigue or depression or anxiety. So there's a lot that this Palliative Care Advisory Committee can do. I really feel like the creation of this is vital to putting patient quality first, meeting the changing needs of the Minnesotans that we have, whether it's aging. In 2030, 1 in 4 will be 65 and older. I hope you support Senate File 112, and I'd be glad to answer any of your questions. Thank you for your time.
Thank you, Mr. Chair and members. I just want to add my own personal story to this and why I became interested. Over the last 4 years, my dad was suffering from congestive heart failure, and I didn't know about palliative care, but I created my own palliative care team with my 3 daughters. And he had numerous heart surgeries, and we found that through massage and essential oils and stretching and yoga and getting his chaplain in frequent, we were able to move him from his transitional care, which actually helped me out a lot here at the Senate. We were on the floor late and wanted to get him out of transitional care and back home. So my daughters were our palliative care team for my father right up to the end. I think a lot of people's misconception is palliative care is hospice care, but it's not. This took place over 4 years when he was diagnosed with a congestive heart failure. So it helped him out a lot, and I wished everybody had access to it or knew about it or how it could help the symptoms of serious disease, which is the reason for this bill. It creates an 18-member, 22-member board. 18 are appointed by the commissioner and 4 legislators. So I would like to move Senate File 112, but I will stand for questions.
Thank you, Senator Housley. Questions?
Thank you, Mr. Chair. Thank you, panel. Thank you, Doctor. I urge members to support Senate File 112. As an attorney of 30 years, I've worked for hundreds of patients and clients that have benefited from palliative care. I think the points that you've made are excellent, Doctor, including the cost savings. Lots of times when we talk about the advisory councils talk about more care, we're saying, what does it cost? But there really are savings to be had. So even if all Minnesotans cared about was the bottom line, I would urge passage of this bill. And since it isn't all we care about and we're talking about quality of life, I think there's even more reason to support it, and I urge members to do so. Thank you, Mr. Chair.
Thank you. Senator Ray.
Thank you, Mr. Chair. And Chair Housley, I like this bill and I'm going to support it. But I have a question regarding payment for palliative care. Is that covered by most healthcare organizations?
I can answer that. It really is in that, but there's not usually a specific carve-out for it. The reality is it's paid for the way you would pay for perhaps home care or other therapies and things like that. Some things are not paid for by many insurances, social work, chaplain, perhaps. We tend to roll that into part of just the cost of managing a patient, keeping them out of the emergency room. So there are some forms of discussion that need to happen there. I do know that there are some, UCare has done some pilot projects with paying for social workers to do special visits and chaplains as well as part of a pilot project. But there are, as far as whether all of the big payers will pay for some of the traditionally non-reimbursed things, generally not yet. But most places can figure out a way to pull that together as they roll it in. Excellent.
Well, thank you, Senator Housley. I also will share something personal on this. I have been involved with several cancer patients in my family. I'm also a cancer survivor. My first spouse passed away after quite a period of illness, and while we didn't have the formal palliative care, the treatment and the care that a person receives in those circumstances is vital to their quality of life and and also to the family members surrounding. And this is sometimes something we forget, that there are caregivers who are family members and they need support as well. And so I strongly encourage this bill to go forward because I think it strikes at a very, very, very important part of the delivery of medical care to people. So.
Thank you, Mr. Chair and members.
So, any other questions? Any discussion? So, all in favor of the bill? Aye. Opposed? Bill carries.
Thank you.
Thank you.